Thank you so much, Dr. Gleave. As you mentioned, I'll be talking today about focal therapy in the primary treatment of prostate cancer. A little bit of an introduction. Yeah, it's Mauritius?
Yeah. That's what I meant. I knew it was wrong. They speak French.
I had a bit of an issue with okay, there we go. So I was lucky enough to be born on this small little paradise island, which is in the middle of the Indian Ocean, which aside from the sandy beaches and tropical weather is also quite relatively unknown in this part of the world, but it's one of the most developed economies in the region, and it is a country with the highest GDP per capita in Africa. And this is my adopted home, which probably will look a little bit more familiar with Table Mountain in the background there. Cape Town is where I had the privilege to train at Brachytherapy Hospital. So focal therapy has been in use for quite some time now in multiple other solid tumors. It is in fact the standard of care for small tumors less than 2 centimeters, not suitable for surgery in hepatocellular cancer. It is also an option to avoid progression while awaiting liver transplantation. It has been used for some time in renal cell carcinoma, where it is used as an alternative to partial nephrectomy in patients with small renal masses who do not want or are not able to tolerate definitive surgery. The 5-year recurrence rate in this particular setting is 94%. Recurrence-free rate is 94%. It has also been used by the thoracic surgeons in non-small cell cancer of the lung. When surgery is not an option, the 2-year survival in this case is 92%. Not quite exactly the same, but similar in concept is stereotactic radiosurgery. It has been used in lesions in the brain, be it metastatic or primary brain lesions that are less than 4 centimeters. So what is focal therapy in the context of prostate cancer? An attempt at definition was made by Pereira et al., who defined it as an ablative strategy targeting a focal area of the prostate where the tumor is located. The overarching themes of prostate cancer in 2018 is to avoid overtreatment of low-risk cancers and potentially expose those patients to unnecessary morbidity risk, but also to avoid undertreatment of potentially lethal cancers. Focal therapy in this regard may represent a middle ground between active surveillance and radical treatment for low-volume localized prostate cancer. Its aims are oncological control, but also to minimize side effects by preserving as much functional tissue as possible, hence improving continence and sexual potency. So we all know that prostate cancer is multifocal. We know that it's in more than 80% of cases, as described by Myers et al. The question is, however, do we need to treat each lesion? And if not, which lesion do we actually need to treat? So proponents of focal therapy argue that despite the multifocality of prostate cancer, there's at least some evidence, be it controversial, that the largest tumor focus within the prostate drives the natural history of prostate cancer, and also that prostate metastatic disease is monoclonal in origin. However, we know that this is an oversimplified concept, prostate cancer being multifocal and genomically heterogeneous, with aggressivity based on genomic rearrangements, copy number aberrations, and single nucleotide variants rather than size alone. We also know that there's evidence of chromosomal rearrangement in metastatic lesions that are identical to those seen in non-index lesions. So I'm having a bit of an issue with it. Yeah. So in the context of low to intermediate risk disease, though, the index lesion can be defined as the largest, more aggressive lesion, as defined by tumor volume and Lesion grade. And this largest lesion with the highest grade is likely to harbor the clone with the lethal potential. So in theory, in multifocal disease, accepting the hypothesis that low volume, low grade residual cancer in the untreated area does not compromise oncological control, focal therapy directed towards the index lesion should result in acceptable oncological outcomes. So different centers have different criteria for who is and who is not a candidate for focal therapy. Tay et al. Propose that the index lesion should make up less than 20% of the prostate volume, with a Gleason score of maximum 4+3, and there should be no pattern 4 in the untreated area of the prostate. But really it's a spectrum, with the best candidate having Gleason 3+4 disease, with low volume tumor, unilateral, and which is unifocal. There are some centers that will push the envelope to bilateral location of the tumor and multifocal tumors. However, we will all agree that patients with high Gleason score and locally advanced disease are poor candidates. Our challenge currently is to preoperatively predict which patient has got a low volume Gleason 4 unifocal tumor, which is relatively rare, and which patient has got biologically significant index lesion with a clinically significant multifocal disease. Because the modalities that we have to preoperatively make those decisions are imperfect. So is a systematic TRUST biopsy enough? We all know that sampling by TRUST biopsy is a function of tumor volume to prostate volume, which is great when you have a large tumor in a small prostate, but not so much if you have a small tumor in a large prostate. This was evidenced by the study by Ward et al. From the MD Anderson Cancer Center. They looked at all their patients where they had a unilateral cancer on TRUST biopsy and went on to have a radical prostatectomy. They had 180 patients, and 83% of those actually had bilateral cancer on their histopathological mount. Is transperineal mapping biopsy better? Well, it should be. We're using a brachytherapy template which is placed in the perineal region, and we're sampling the prostate at every 5 mm interval so as to uniformly sample the gland. However, it's not perfect. This was a study by Scott et al. Published in 2013. They compared the extended TRUST biopsy against the transperineal template biopsy, and those patients eventually had a radical prostatectomy. And they looked at the whole mount radical prostatectomy specimens. They found that in 22.3% of patients, they were in the TRUST biopsy group were upgraded to a higher risk group. And it was still significant in the transperineal mapping biopsy group, where 14% of patients were upgraded to a higher risk group. And to mention the fact that transperineal mapping biopsies requires a general anesthetic, it's associated with increased discomfort, there's an increased rate of acute urinary retention, and above all, it is costly. So is MRI the answer? We all know this study. It was published in The Lancet in 2017. It's a PROMISE study. So those guys compared an index test, which was the MRI. We had 576 patients, and those patients eventually had a transperineal mapping biopsy. An MRI identified 418 lesions, 400 patients with significant lesions, of which 213 actually had significant cancer. There was 158 patients where there was no suspicious lesion identified, and 17 of those turned out to have significant cancer. So this resulted in a sensitivity for clinically significant prostate cancer of 93% and a negative predictive value of 89%, which is particularly important in focal therapy where we're planning to spare a portion of the prostate. However, there were some limitations to this study where clinically significant prostate cancer was defined as Gleason 4+3, and also the fact that the histological standard use was a transperineal mapping biopsy, which although very good in terms of histological diagnosis, is not perfect. We also know that MRI significantly underestimates the tumor size. That was a study published in 2017 by Priester et al. That 114 men who had a multiparametric MRI followed by a radical prostatectomy. The MRI did detect 82% of index lesion, However, the tumor diameter was underestimated by a mean of 11 millimeters on T2 imaging. In view of the current limitations of our imaging modalities, there is a lot of research going on in terms of future imaging modalities. One of them is RFI, or acoustic radiation force impulse. It is an ultrasonic elasticity imaging modality which basically measures the tissue, looks for tissue stiffness changes. And it has been shown that it can identify up to 79% of clinically significant prostate cancer. There's a lot of promise with the 7 Tesla MRI. Phase 1 and Phase 2 trials have shown encouraging results in abdominal imaging. And indeed, a study by Duran et al. Reported that ex vivo 7 Tesla MRI was able to identify malignant glands and nests of tumor cells similar to low-power microscopy. The combination of gallium-68 PSMA PET with MRI has also shown an improved AUC for detection and localization when compared to MRI alone. And radiomics, which is an automated extraction of large volume of data from medical images, which could potentially improve accuracy of image interpretation by reducing the human factor. Unfortunately, we don't have guidelines in focal therapy, but only consensus statements by interest groups. And we can see that the current recommendation from 2017 in terms of cancer determination is to do a multiparametric MRI, followed by target and systematic biopsies. The goal has shifted from 2010, where it was to eradicate all cancer. It's now to eradicate clinically significant prostate cancer and disease factors as well. Patients in the intermediate risk are now considered for focal therapy with up to a millimeter of Gleason 3+3 disease in one core in the untreated lobe. However, we can note that those statements were published in a relatively low-impact journal, probably because it is still an evolving field with limited high-quality evidence. There are numerous ablation strategies that can be used. One is targeted ablation, where only the tumor focus is targeted with a margin of tissue. Quadrant ablation, hemiablation, or hockey stick ablation. The trend currently is towards more focused treatment, and indeed many centers have been moving away from the traditional hemi or hockey stick ablation to a quadrant type ablation. Still, many centers are reluctant to restrict to targeted ablation because it is known that current imaging modalities underestimate tumor size, and targeted ablation has been associated with residual disease. So this is a non-exhaustive list of all the energy sources available in focal therapy. HIFU, cryotherapy, and focal brachytherapy are the more common ones, and there's a lot of research currently on photodynamic therapy and irreversible electroporation. In terms of HIFU, an ultrasound probe is inserted transrectally. It allows visualization of the prostate and also generates high-intensity focus ultrasound, which passes through an acoustic lens, increasing temperature at the focal point and leading to local necrosis. Usually, MRI fusion platforms are used to target the lesion, and it is the least invasive of all focal options. There are certain limitations to HIFU, though. The patient should have minimal calcifications within the prostate. There should be no severe anal stenosis. Prostate size is a limiting factor because of dissipation of ultrasound waves at longer focal point, and this is further compounded by tissue edema. There are limitations as regard to treatment of apical lesions because application of thermal energy close to the sphincter can lead to sphincteric dysfunction. So the recommendation is to maintain a 6 mm safety margin from the apex. This is a Uchida grading system. So when we're doing focal therapy on the truss ultrasound, we can see a popcorning effect in the focal area of treatment. And what we want to see is what's there in grade 1. So you expect discrete popcorning effects. We don't want to see grade 3, where you can see that there are concurrent popcorning effects that's extending beyond the focal area of treatment. And grade 2 is a warning that we might move into grade 3 so as to reduce the power. This is a study out of Toronto where they demonstrated the feasibility of MR-guided HIFU for focal therapy. The advantages being real-time tumor visualization and temperature monitoring. It was a small phase 1 trial with only 8 patients, Image A shows the pre-treatment images with the blue line surrounding the prostate, the yellow line surrounding the tumor, and the red line pointing to the rectal wall. Image B represents an intraoperative MR images, which shows a focused ultrasound beam overlying the treatment plan. Image C is a thermal map obtained during treatment, and image D is the contrast-enhanced MRI after treatment. So I think this slide illustrates well the functional outcomes in terms of focal therapy as a whole. You can see the blue line represents bed-free continence, green line leak-free continence, and red line erection sufficient for penetration. So we can see that there's an initial dip in all the functional outcomes, followed by gradual recovery. The recovery is complete up to baseline in terms of continence. However, there is a gradual recovery in terms of erections after focal therapy, but it doesn't quite reach baseline. This was a study that was published in 2017, Wixman et al. It was a prospective multi-center study. They did a biopsy at 1 year, where 95% of patients had no clinically significant disease. At 2 years, 89% were radical treatment-free. However, this is not very surprising since most of their cohort were low risk. The IPSS score was improved by a mean decrease of 3. They also assessed pad-free continence, where 97% of patients were pad-free at 1 year. There was a mean decrease in the IIEF score of only 1.2 at 12 months, but only 78% of patients returned to their baseline erectile function. That's a very good study by Guillaume et al. It was published in October 2018. It was a prospective single-arm cohort study with 625 patients. This study was loaded because they actually described that 375 patients were intermediate risk and 189 patients were high risk. And their failure-free survival at 5 years was excellent at 88%. They defined failure-free survival as avoidance of surgery, radiation, and no metastatic disease. However, when you look a little bit more closely to their data, 83% of their patients had Gleason-free predominant disease. There were only 11 patients out of the 625 who had high-risk disease by Gleason criteria, and they didn't do systematic biopsy as part of their follow-up. Those patients were only followed up by PSA kinetics and MRI imaging, which could have led to an underdetection of significant prostate cancer. In terms of adverse events in this study, the most common ones were urinary tract infections in 8.5% of patients, epididymolysis in 1.9%, and rectal fistula was a very rare complication in only 2 patients out of the 625, one of which it resolved following catheter drainage. The other one required surgery. Moving on to cryotherapy. It is done by placing cryoprobes and thermocouples transperineally into the prostate via truss guidance. A urethral warming catheter is used to limit urethral morbidity. And we monitor the freezing process in real time. You can see the formation of an ice ball. The goal of treatment is to ensure -40 in the target tissues as well as the margin, and temperatures above freezing around sensitive structures. 2 freezing thawing cycles are used. As the mechanism of action of focal therapy, it's based on the Joule-Thomson effect, which is a cooling effect experienced by a gas as it moves from a high pressure region to a low pressure region, results in freezing at the tip of the cryoprobes. Freezing results in formation of extracellular ice, hence increased extracellular osmolarity and movement of water out of the cell. There is also formation of intracellular ice, leading to damage to organelles and cell membrane. During the slow thawing process, ice is melted first extracellularly, which increases the free extracellular water, reducing osmolarity and causing movement of water into the cell. Movement of water causes increase in the size of the intracellular ice and cell swelling and bursting. In a delayed fashion, there's inflammatory cells that migrate to the necrotic tissue, releasing cytokines causing apoptosis. This study I thought was very good. Oishi and Al published in April of this year. It was a prospective cohort study including low, intermediate, and high-risk patients. They did hemiablations for all their patients and did an MRI at 3 months, 6 months, and 12 months, as well as biopsies at 12 and 36 months, all for cause. It was quite an intensive follow-up. So 121 patients were defined as intermediate risk, 28 patients as high risk, but again, the PSA values in those patients were quite low at 6.7 and 7.1. In terms of follow-up biopsy outcome, at 3 years, there was 30% of patients with residual cancer, and 17% of patients had clinically significant residual cancer after treatment, and that was at 3 years. In terms of 5-year radical treatment-free survival, it was 85%. In terms of functional outcomes, we can see across most of the cryotherapy studies, continence is very well maintained. Almost all patients return to their baseline continence, which is, and in terms of potency, there is a significant drop in the number of patients who actually become post-operatively potent. And that's across all studies. Other adverse events, that's from the core registry, which is a cryo online database. It's a retrospective database for cryotherapy users. Perineal pain is listed as one of the most common ones at 12%, urinary retention up to 5%, urethral stricture disease in less than 1%, and rectal fistula in 0.4%. So rectal fistula and urethral stricture disease, which seem quite prevalent in the earlier studies, are close to 0% now in contemporary studies. This also was a very interesting study by the group at MD Anderson. It's still unpublished. It was a prospective cohort study with 23 patients, so a small number. In this center, they all had a hockey stick template. Again, quite intensive follow-up with routine post-ablation biopsies at 6, 18, and 36 months. There was only one patient with infill recurrence at 36 months. And in terms of sexual and urinary outcomes, there was almost complete recovery of urinary function and significant recovery of sexual function. So this begs the question of whether we should limit the ablation field if functional outcomes are more or less similar to a more focal ablation and oncological outcomes possibly superior. As with all technological advancements, there are certain limitations to cryotherapy. We know that nerves are very sensitive to low temperature, with damage starting at 3 degrees Celsius and becoming irreversible at -15. This led Coleman and al. To suggest that treatment of posterior lesions using cryotherapy increases the probability of nerve damage. Muravlev et al. Also demonstrated that central tumors show an increased recurrence rate after cryotherapy, which is likely from the use of a urethral warming catheter. Moving on to focal brachytherapy, it is the placement of radioactive seeds if it's LDR, or a source if it's HDR, within a specific area of the prostate so as to cover the index lesion. The biologic effects result primarily from damage to DNA. This was a study by Peach et al. Did a systematic review, mostly dosimetric studies in this paper. However, they concluded that the radiation dose to organs at risk were reduced when compared to whole gland treatment, which should in theory at least result in decreased toxicity. But the problem with brachytherapy studies is they kind of follow up their patients with PSA kinetics only, and very few of them actually have a biopsy. The one with the most biopsies that I found was a study with 21 patients, and only 6 of them had a biopsy, in which 5 was negative and 1 with Gleason 3+3 on the contralateral side. But with such small numbers, it's really difficult to conclude what the oncological outcomes were. However, in terms of urinary and sexual toxicity, the outcomes were excellent. The initial IPSS score was 5.4, and at 12 months, 6.1. Initial IIEF score was 20.1, and at 12 months, 19.8. However, we do know that with brachytherapy, the side effects tend to take a long time to show up. So it would be interesting to know what those results are at 3 and 5 years. Irreversible electroporation is a new energy modality. It uses a pulsed high voltage low energy current to create micropores within the cell membrane and eventually leading to cellular apoptosis. It allows complete ablation of tissue within the chosen field, advantage being that it doesn't have a thermal effect. It was a retrospective database review by Vandenbos et al. They had 63 patients. Again, AUA score and EPIC urinary summary score. There was no significant difference between baseline and 12 months, so excellent recovery. And again, sexual function summary score, a significant decrease from a baseline of 66 to 48 at 12 months. In terms of oncological outcomes, 15.6% of patients had significant infill disease, and 9.8% of patients which had significant out-of-field disease. So relatively poor outcomes in this study. Laser ablation, first described as a treatment option in 1993. They use an iodinium or diode laser. It results in coagulative necrosis within the prostate. In terms of we can monitor the treatment in real time with MR thermometry, and the laser fibers are usually positioned transperineally. This was a study by Egner et al. Published in the Journal of Urology in 2016. They had 27 patients, most of them with low and intermediate risk disease. Systematic 12-core biopsy at 12 months, 37% of patients with residual cancer, 11% within the ablation zone. There was no significant change, however, from baseline IPSS and SHIM scores at 12 months. Another new treatment modality was vascular targeted photodynamic therapy. It consists of ablation of a tissue, which is achieved by activation of a vascular photosensitizer by wavelength of light. This causes release of reactive oxygen species and vascular occlusion. The photosensitizing agent, which is usually pedidiporphin, is given IV, and the wavelength specific to its activation is delivered by a laser fiber. Again, the advantage of this technique is that it's athermal. So that's one of the very rare randomized controlled trial in focal therapy. It was published this month in the Journal of Urology. 413 patients, they compared VTP to active surveillance. Their primary endpoint was treatment failure, and we can see that the rate of conversion at 4 years for VTP was 24% against 53% for active surveillance. However, when you look more closely at the reason why they were converted to radical therapy, you can see that a higher percentage of patients in the surveillance group were converted because of increased volume of disease rather than increase in the Lesion grade group. This is a non-exhaustive list of all the side effects they describe. So in summary, 30% of patients in the VTP group had a serious adverse event, where compared to 10% in the active surveillance group. At 24 months, however, their sexual and urinary function was similar between the two. So in summary, in this study, a significant reduction in progression to radical treatment was noted in the focal therapy group. However, to achieve this outcome, all patients suitable for active surveillance would have to be treated, exposing them to significant adverse events. What about the follow-up after focal therapy? It's vital. We need to detect infill residual tumor and out-of-field new tumors. There are various follow-up protocols out there. All of them make use of, to some degree, of PSA kinetics, which we know to be unreliable. We should, however, still expect a 50% decrease in PSA after adequate treatment of the tumor. MR imaging and controlled prostate biopsy, which is mandatory after focal therapy. What we expect to find on biopsy is the absence of tumor in the treated zone, and a very small amount of Lesion 3+3 may be accepted in the untreated zone. So MRI after focal therapy can be early or late. MRI delineates necrosis and provides early feedback regarding extent of treatment. However, is this good enough to ensure the tumor has been ablated? The short answer is no. MRI images early after therapy correlate poorly with a positive biopsy at 6 months. Late MRI, however, is quite useful to detect residual tumor in the treated area or a new lesion in the untreated area. T2 imaging is less valuable in this setting. than pre-treatment, because fibrous tissue, which will eventually replace the necrotic area, also has a low signal. We rely more on early enhancement on dynamic contrast imaging and restricted diffusion on the EDC map. So how good is MRI after focal therapy? This was a study by Louise et al., which is a group in London, published in 2017. They had 118 patients and a very high negative predictive value of 96%. However, the highlight here is that they grossly undersampled the prostate. They only took 6 cores per prostate as part of their prostate biopsy. The consensus for follow-up following focal therapy is summarized in this flow diagram, which was proposed by Muller et al. In 2015 following a Delphi consensus project. PSA is recommended every 3 months, and initial MRI at 6 months, and systematic and target biopsies of the target lesion and suspicious lesions at 12 months, followed by yearly MRI. Follow-up is terminated at 5 years if the multiparametric MRI and PSA are deemed reassuring. So what do we do if we have a recurrence or a new lesion? We have limited data available regarding this, and there is no recommendation from consensus meetings. It's largely based on individual parameters and patient-physician preferences. Options include active surveillance if it fits the low-risk criteria, possibly redo focal therapy in case of low-volume intermediate-risk disease, and radical treatment for larger volume, larger-grade disease, higher-grade disease. Their role for biomarkers in this setting. We all know about the cell cycle progression score and the GPS score. However, it could potentially be useful, but there's no validation studies in this setting. The other important question that we need to ask is if focal therapy compromise future radical treatment. This was a study published by Lebda et al. In the World Journal of Urology in 2015. Not very good study, but they had a case series of 19 patients who had a salvage robotic-assisted radical prostatectomy after focal treatment, 14 of whom had only one lobe treated. All had VTP. The median delay between VTP and radical prostatectomies was 17 months. At 10 months, the PSA was undetectable in 16 out of the 19 patients. There was, however, a positive surgical margin in 9 patients, and the continence at 10 months was only 68%. Moreover, erectile dysfunction was seen in 18 out of those 19 patients. And this was a bit of a better study. Unanswered et al., that's a group in Paris. 1:2 match pair analysis. 22 patients had salvage robotic-assisted prostatectomies, and 44 had primary robotic-assisted prostatectomies. In terms of outcomes, we can see that there is no real difference in terms of pad-free continence rate. The IIEF-5 score, however, was significantly worse in the salvage group, and even more worrying was the median time to biochemical failure, which was significantly worse in the salvage group, with a biochemical recurrence-free survival at 2 years of 56.3% in the salvage group compared to 92.4% in the primary group, which either suggests local progression during the follow-up period after focal therapy, or perhaps increased surgical difficulty. So what do the guidelines say? AUA, ASTRO, and SUO mentioned that prostate cancer is often multifocal, so clinicians should inform their patients that focal therapy may not be curative and that further treatment may be required. The EAU mentioned that focal therapy appears promising, but remains investigational because there are uncertainties surrounding retreatment and follow-up. So because of the lack of validated data, they both mentioned that focal therapy remains experimental. We also have a lot of unanswered questions in focal therapy. Are we really saving a significant proportion of patients from radical tape treatment, or are we delaying the inevitable? We don't really know what proportion of patients will eventually need salvage treatment in the long and very long term. And salvage treatment in this particular population of pre-treated patients seem to be associated with worse outcomes. We don't know what the history of the non-indexed lesion is, particularly with change in the microenvironment following therapy. And we don't know if the residual cancer after ablation behaves more aggressively. So there's a recent momentum to focal therapy through convergent advances in imaging and targeting system. The best candidates are those with unifocal low-volume MRI visible, Lesion 3+4 disease. However, it remains experimental at this point. Our current imaging modalities are not accurate enough to identify all lesions. There's also a lack of evidence pertaining to long-term oncological outcomes, and we still have a lot of unanswered questions. That's it. Thank you.